Okay, I am back. Hear me? My signal doesn't look too good, you know. My signal is not strong. So I'm giving my signal a couple seconds to go up. Hmm. Hmm. All right, you should be able to hear me now. All right, so I'm gonna, okay, all right, hold on a sec. Think I may have, all right, the signal is up now. All right, so the scenario that you were given for the upper airway management tabletop evaluation was you have a elderly male patient found at home by family members in bed. The patient is not responding. You start with your standard precautions. So I'm going to take standard precautions. Definitely will have my gloves. Need to consider covering my nose, mouth, and eyes. So you take standard precautions. I'm going to make contact with the patient. Hello, sir. Can you hear me? I don't get any response to verbal stimuli. I apply pain at the supraorbital nerve. Patient doesn't respond to pain at this point. The patient is unresponsive. I am not suspecting any C-spine at this point, so I'm going to perform a head tilt chin lift. Use one hand to maintain the head tilt. Use the free hand, 2 fingers of the free hand, to palpate the carotid pulse. At this time, I'm ensuring that the upper airway is clear, and it is clear. However, I'm not seeing any chest rise. There is a pulse. I am going to check the rate of the pulse by counting the pulsations for 15 seconds multiplied by 4. I am checking the checking the rhythm of the pulse, its consistency. Is it fast, then slow, or is it consistent or regular? Right now, it is regular. Is it strong, weak, or does it feel normal? At this point in time, it is weak. So the patient has a pulse rate of 46 beats per minute, regular, weak, carotid, right side. There is no chest rise at this point. The patient is unresponsive, and OPA is indicated. I'm going to take the OPA. I'm going to measure from the corner of the mouth to the earlobe. I'm going to insert the tip of the airway adjunct towards the hard palate, rotate 180 until the flange rests outside the lips. Once the airway adjunct is placed inside the patient's mouth, I'm going to take my BVM using a EC technique, and I am going to prepare to provide positive pressure. As soon as oxygen is available, I'm going to have it attached to my BVM, high flow 15 liters per minute. I'm going to give one breath every 5 to 6 seconds. After 2 minutes, I'm going to evaluate to ensure that the pulse is still present. Patient start to gag. At this point, I stop my positive pressure, turn the patient's head to the side, quickly pull the airway adjunct out, observe the secretions coming out of the mouth. At this point in time, it is a large amount of secretion, so a rigid suction catheter is indicated. I'm going to turn on my suction machine, ensure that my rigid catheter is attached, kink the tube in, get it up to 300 millimeters of mercury, test the suction, measure the suction, corner the mouth, earlobe, insert until it is touching the fluid or to the point that I can see. Once it's inserted inside of the fluid, I'm going to initiate suction, moving side to side or in a circular motion out. This is an adult patient, so I will not exceed 15 seconds. After I've cleared the airway, I'm going to reposition the patient's head and reevaluate the patient's level of consciousness. Sir, can you hear me now? No response. Apply pain. Patient groans. Pain would be applied to supraorbital nerve again. Patient groans. At this point, perform a head tilt chin lift. Maintain the head tilt chin lift with one hand. Use the free hand, the fingers of the free hand to simultaneously check for a pulse, carotid pulse. At this point in time, there is chest rise. So I will evaluate that chest rise by counting the breathing rate. I will be looking at the rhythm, chest rise bilaterally, whether or not there are abnormal sounds present, and I will consider the pulse ox if it is on my patient at this point. Patient is currently breathing at 6 breaths per minute, and that breathing rate would have been calculated by counting the rise and fall of the chest for 30 seconds and multiply by 2. I am seeing movement of the chest bilaterally, but it is poor chest rise. At this time, I cannot hear any abnormal sounds without auscultation. The pulse ox is below 90. Based on the patient current presentation, an NPA is indicated, or nasopharyngeal airway. I'm going to take the nasopharyngeal airway, measure from the tip of the nose to the earlobe in the position of function. I'm going to lubricate the NPA, or nasopharyngeal airway. I'm going to ensure that the bevel is pointing towards the septum. I'm going to insert that device into the right nostril, which is the larger nostril. I will then take my BVM with oxygen source attached and initiate positive pressure ventilation. However, at this point, because the patient is now showing chest movement, for the first 5 or 10 ventilations, I will squeeze the BVM when the patient breathes in, and then I will regulate it at 1 breath every 5 to 6 seconds. This will be done until the patient is able to breathe on their own, or I hand this patient over to somebody at my level or higher at the hospital. That would be the end of the skill station. That is what I'm looking for. Any question or questions? Yes, go ahead.
Yes, sir. Being there, sir.
Yeah.
When you insert the nasopharyngeal adjunct, sir, you say to the right nostril, but I'm confused as to my right or the patient's right.
Must be the right to the patient. And
Okay,
if
sir.
I am at the head, is your right? Yes?
Yes, sir.
Good. because
Sir,
that's where you work from when you're doing airway management. You work from the patient head, so if it's their right, it's your right.
sir, you said you would apply the BVM using the EC method.
Yes, EC technique.
So what exactly is the EC technique, sir?
Have you reviewed your airway lecture?
Yes, sir.
All right, review it again. You'll find the answer in that lecture. Any other question?
Earlier you said to Baines, sir, that it's not possible for him to check the pulse and do the healthy chin lift, sir. But I see you.
That's not what I said. Again, pay attention. What Mr. Bain said was he's going to check the pulse and put in an airway adjunct. Two different things.
Okay, sir.
Pay attention. Any other question? Yes, go ahead.
Yes, sir. Is it okay to do the head tilt chin lift with a patient on a bed?
It can be done if you know what you're doing. So if you're controlling there's two ways to do a head tilt chin lift. You have the approach that you use if the patient is on a flat surface. If the patient is on a flat surface, one of your hand goes on the patient forehead. The other hand, the two fingers go on the mandible, and you do your head tilt chin lift. If you have a patient on a bed, you have to control the base of the patient head. And if you're controlling the base of the patient's head, you can do a head tilt chin lift. Any other question? Go ahead.
Yes, sir. I just want to reflect back on anatomy, the skeletal bones. Here we see there's 14 bones. No, sorry, 206 bones for the human skeleton. Is the tooth a part of the 206, or is it not?
I don't know the answer to that question. I would suggest you search for it. Any other question as it relates to the skill station? Yes, go ahead.
Sir, in relation to upper airway management overall,
Yeah,
is really the ventilation we are focused on in terms of trying to fix the problem.
we're not only focusing on ventilation, there are several things that are happening. And if all you see is ventilation, you're not seeing the entire picture. We cannot ventilate if there is no way to keep the tongue out of the patient's airway. Right? Your hands need to be free to ventilate for the patient. In order to free your hands, the use of an airway adjunct will assist you to do that. So there are two components. There is being able to choose the appropriate airway adjunct. The other component, well, it's actually three components. Being able to choose the most appropriate airway adjunct, suction the patient's airway, and the BVM component. So it's three components that must be done properly. So it's not just BVM. It's how you maintain the airway. It's how you clear the airway if you need to suction. And it's how you bag the patient if you need to bag the patient. And of course, it's your ability to assess the patient as well. A patient with an airway problem. Any other question? Is it clear what is expected?
Yes, sir, it's clear.
All right. What about the others? You won't hear me go through this again. Speak now or forever hold your peace. Is it clear now what is expected? Mr. Powell, we clear at this point?
Yes, sir.
Miss Wellington, you clear at this point? You present, Miss Wellington? Okay. Mr. Wilson, we're clear at this point.
Well, sir, if you could adjust for my clarity, from when the patient start gagging, if you could just pick up from there, so for me.
That's not gonna happen again. You know why? It's being recorded. So if you want to review what it is that I went through, if you have your access, you can find the recording on the platform. So I'm not gonna go over it again. It has been recorded. So it's on the platform now, right?
Yes.
What you need to get is the principles. There must be a clear approach to your assessment. You must be able to recognize that the patient requires a airway adjunct. You must be able to demonstrate proper knowledge of positive pressure ventilation or artificial ventilation with a BVM and high flow oxygen source attached. You must be able to appropriately manage the patient's airway if the patient starts to gag and is about to vomit. You must demonstrate proper suction procedures using the most appropriate suction catheter. You must demonstrate good reassessment of the patient and determine that an NPA is required. That is what is expected of you. For those of you who now have access, let me show you how you will find. So let me stop this.